Welcome to an episode of the EAU's podcast series. This is a special historical episode, perhaps unusual. We're doing this for the first time. My name is Loek Keizer. I work for the EAU Central Office for the Communications Department as an editor, and I'm the author of the book EAU 50, about the EAU's 50th anniversary 2 years ago. And I work closely with the History Office. And in that capacity, I'm joined by Professor Philip van Kerrebroeck, based in Antwerp, chairman of the EAU History Office, and currently also vice chair of the EAU Policy Office. Professor van Kerrebroeck is an expert in continence, health, and functional urology, formerly head of the Department of Urology at Maastricht University, and he has 35 years of experience in neuromodulation. And today we will be talking about the use of electricity in urology, specifically the history thereof. Welcome, Philip.
Thank you, Luke. My pleasure to be here.
When we talk about electricity, the listener might think we would be starting in the 19th century when the discovery of electrical properties and the invention of batteries and things like that happened. But apparently there is even evidence of times from ancient history when electricity was already therapeutically used. Could you explain, Professor?
Yep. Well, that's absolutely correct. As you said in the introduction, indeed, I've been working for 35 years with electricity as a urologist. And even after 35 years, for many people, even for the colleagues, it is still a little bit enigmatic. Because most of the urologists, of course, are not used to work with electricity. And we use electricity for functional problems. So it's a functional therapy, which is a completely different concept than the classical urology, where you will take out an organ because it has cancer or it's not functioning well. We restore the function with electricity. So that is already a first hurdle, which has as a consequence that people doing this type of therapy still quite often are seen a little bit as magicians or witches, depending on how positive or negative the colleagues are towards the people busy in functional urology. But as you correctly say, the use of electricity leads to a lot of modern technology, and a lot of actual development is going on in the field. But when we go back in history, and that's the main purpose of the podcast that we're recording today, when we go back in history, in fact, the first documentation on the use of electricity is from the ancient Egyptians. Because indeed, there is Chester Beatty manuscript, a papyrus, dated 1570 before Christ, so nearly 4,000 years ago, where the use of natural electrical current is described for different ailments. And amongst these 8 ailments is indeed also bladder problems. Of course, it's not specified what kind of bladder problems it were, but we can imagine that overactive bladder, which is a modern problem, already existed in the ancient Egyptian bladder. And so we can suspect that electricity that we use now for overactive bladder was used by the ancient Egyptians for that same indication. I said before, they used natural electricity because, of course, as you say, most people will connect electricity with the 9th century and the batteries. We'll come back to that in a few moments probably. But there are also natural sources of electricity. And indeed, in Egypt was living a fish or an eel, we should rather say, that produces a natural electricity. And that was put indeed on the places on the human body that were not working properly. And so we can imagine that is not described in detail in the papyrus, but that this eel was put on the lower abdomen of somebody that has bladder problems, and apparently with good results.
So the fish was directly applied to the body?
It was direct application of the body because, of course, it is low current or low voltage that is produced. So you need quite a good contact between the source that's producing the electricity, the eel in this case, and the skin of the patient, and then transmitting the electricity, the current to the end organ, which probably was the bladder.
So not in a bath or anything like that, but
that is definitely not described in the manuscript, and it's not very probable because with the water you would lose a lot of current so the transmission would not be optimal, and the current would spread over the whole body. So you would have a low threshold stimulation over the whole body, but not the maximum stimulation at the level of the problem.
Yeah. And we probably don't know what sort of results were achieved with this.
Well, they describe in the papyrus that this is a very useful therapy. I don't know if we could call that evidence-based on Egyptian literature, but anyhow, there were indications that it had success. Now, we have to put some remark, because we know that in functional problems, whatever we do has a 40% placebo effect. That, again, is not something that has been invented in the 20th century. That also existed in the Egyptian time, probably. So we can suspect that also this electric fish or the natural current produced a placebo effect. And that could be that was what is described in the papyrus and not a net effect. But that, of course, we cannot retrace. But it is known that even a low threshold stimulation, as you can achieve with this electric fish, indeed can have an objective effect on the human body.
Maybe if we now take it to the time when mankind got more acquainted with electricity, so we're talking about the late 18th century, 19th century, some famous names whose names are very much connected to electricity.
Yeah, that's a big jump, because then we would go already to the 18th century in Europe, which is about 3,000 years jump. So a lot of work has been done in between. And this is an interesting aspect of looking at the history of electricity in urology, is that you have this flow in history at different levels. First of all, going from natural electricity, as we just discussed in Egyptians, to electricity produced artificially, and then we come to the battery as it has been developed in the 18th century. We'll come back to that in a few moments. But also the different indications for the use of electricity, because today we're discussing electricity in urology, but electric current is used in different problems. And most people probably are very familiar with cardiac stimulation, with the cardiac pacemaker. But indeed, a pivotal moment is the 18th century, where there was a possibility of producing artificial electricity. But for example, Scribonius Largus, a Roman physician, made already a book uniquely devoted to the use of electrical current, electricity, for different pathologies, not only urology, of course. But it's quite correct to jump to the 18th century.
Where was Scribonius getting his electricity from?
Also from natural sources. Probably not electric fish, but for example, if you take skin of sheep, for example, and you move them, you produce friction that also can give electricity.
Static electricity.
And so that was the way, as it has been described by the Romans. They also, when you cause friction with certain metals, between metal and stones, precious stones also can produce. So there are different ways of producing natural electricity that have been used before the batteries came into place. To come back to the history of the use of electricity, not only there are these technical aspects, going from natural electric current to produced or artificial electric current, but there is also the way the current is applied. We were discussing direct contact between the source of the electricity and the body, but probably the older people listening still had to do the frog experiments during their medical studies, where we had to do, I at least had to do that, but I studied medicine in the 70s of the last century. We still had to do stimulation of frog legs. And that indeed was based on the experiments of Galvani in 1791, where he could show that when you stimulate the muscle of the leg of a frog, that the leg is contracting. And so that was an explanation or a demonstration that direct stimulation of a striated muscle can produce contraction of that muscle, and in case of the muscle of a frog leg, the frog leg moves. So that is already fundamental discovery that we take for granted, and that's quite logic, but that was a major step in understanding the role or the potential role of electricity and the action that electricity can have on the human body. Then the next famous name that also many people know is Volta, because he gave his name to the intensity of current, the volt. So Alessandro Volta was an Italian born in 1745 that indeed produced the first battery that could produce artificial electricity. Not only that, Volta also did animal experiments where he could show that when you stimulate a nerve that leads to a muscle, that also nerve stimulation can produce contraction of a muscle and eventually contraction of a limb or another organ. Now, stimulation can be produced not only with electricity, but also with magnetic current. And that is then a Danish discovery, as Hans Christian Ørsted, born in 1777 in Denmark. First of all, did the experiments with magnetic stimulation, with strong magnets, but also describes for the first time the term current, meaning electricity that goes from one point to another and as such produces the stimulation. So that was the next important clinical step is by Guillaume Duchenne. That also is a familiar name for most people, although mainly from the neurological point of view. But Duchenne did very nice experiments in the midst of the 19th century, where he put electric current on different points on the face of volunteers and could show that with electric stimulation at one point, there is a contraction of different muscles which produce a certain movement in the face and could even give an expression of emotion. So that again was a form of what we would call functional electrical stimulation, which was again a major step in understanding the working mechanisms, but also the possibilities of the use of electricity in the patients.
And if we turn to urology specifically, what were some of the earliest developments there?
Yeah. Well, a very interesting concept is presented by Matthias Saxtorp, was a physician living in Copenhagen. He was born 1822, and he applied for the first time intravesical electrical stimulation. So he made a probe, and at the end of the probe was the possibility of producing an electric current. So he put his probe through the urethra in the bladder, put electric current on the tip of that probe, and could see that he could provoke a bladder contraction. So that was, in terms of the use of electricity within urology, was a major discovery, because that was the first time that one of the urological organs was directly stimulated and produced a functional result, a contraction.
He was trying to achieve a contraction.
He was achieving a contraction, and his primary aim was to develop a treatment modality for people that cannot contract their bladder anymore, that were in retention. Now, so that was 1878. Now, in fact, he was disappointed with the results because, as we know now, many people that have lack of contraction of the bladder, there is damage to the bladder muscle. So you can provoke stimulation, but if the muscle is destroyed, then the contraction will not happen even with electric current. But the interesting thing, and this is also a lesson from the history in general, but definitely also from the history of the use of electricity in urology, is that in the course of history, you see some modalities or therapies that come up, finally are a failure. But then years later, it appears that with sometimes even the same technology, but with another form of application or for another indication, that therapy can work. We'll come back to that probably later with some future developments that are based on methods that have been tried more than 100 years ago. But also this method of Saxtorp with intravesical stimulation has been used in the 60s by a Hungarian pediatrician, in fact, in children that were born with meningum ileal, with spina bifida, that we know when we don't treat the bladder, and to treat their bladder is quite difficult, when we do not treat their bladder, they get into major bladder problems. The bladder wall gets very thick, they get infections and so on. And this Hungarian pediatrician retried the method of Saxtor, put a probe into the bladder of these children, and they were just born. So their bladder condition was still okay, but because of the neurological deficit, they could not contract the bladder. And with the intravesical stimulation, he could show indeed that these children could contract their bladder. But also, if you apply this technique on a chronic basis, their bladder does not get as abnormal as if they're not treated. So you would say, wonderful treatment. Unfortunately, it's quite an invasive method because that means that you have to take a newborn baby with spina bifida because you have to start very early, put the probe through the urethra and stimulate. So based on practical limitations, this never has been a success, although there have been publications in the 60s and up to the 70s. For example, Madesbacher in Austria repeated these experiments that could show very nice results with this intravesical stimulation. So this Hungarian doctor was Dr. Katona. So in the modern literature, well, let's say literature of the 20th century, you will find it as the Katona stimulation, but it would be more appropriate to call it the Saxtorp stimulation, in fact. So then the next important step was, in fact, we've been discussing production of artificial electricity with batteries, but a major step was in the 20th century, more specifically 1934, when the first implantable battery was developed. That means a battery that could be implanted in the body, could be connected with an electrode, and then could produce stimulation. And that was indeed the heart pacemaker or the cardiac pacemaker that has been developed in Harvard University by two very bright figures, Leon Chaffee and Richard Light, that together developed this battery. And you can imagine this was a major step if you count the millions of people worldwide that have been treated and are living thanks to cardiac pacing. And also this was important because that was the beginning of the whole development of pacemakers for other indications, as in urology, as we will discuss.
Implants.
Implants in a few moments. There is still some interesting urological developments in between. That was direct bladder stimulation, where electrodes are put on the bladder wall, and direct sphincter stimulation, where electrodes were put on the urethral sphincter. The electrodes on the bladder to provoke contraction of the bladder, electrodes on the sphincter to provoke contraction of the sphincter, for the bladder for people that cannot pee, contraction for the sphincter for people that have stress incontinence. Indeed, both techniques worked, but were not a success, because with the technology of that time, the electrodes that were put on the bladder wall detached because the bladder, of course, moves with contraction. And also it was discovered that when you stimulate the urethral sphincter, which is a striated muscle, that with electrical stimulation, you get fatigue. And the sphincter gets weaker instead of stronger, definitely in an acute setting. And so this method were abandoned. We know now that with adapted stimulation programs, we still can stimulate striated muscle. And actually, there's a lot of research ongoing to see if direct sphincter stimulation would be a new possibility, as also new stimulation technology where kind of a network of electrodes can be put around the bladder and be used to contract the bladder. So that's again a way how historical facts are important to study again, because they can lead to future developments in the same field. Then when talking on the battery, then we come to, in fact, the bladder pacemaker. But there again, there was a major intellectual step that had to be taken, because we're talking now in the 70s, where two gentlemen in London, Giles Brindley, and in San Francisco, Emil Tanago, were both thinking on how can we help people with electrical stimulation. They were both convinced of the usefulness of the use of electricity. Giles Brindley more in the field of patients with spinal cord injury, and Emil Tanago also in patients with spinal cord injury, but more also with people with overactive bladder. Giles Brindley went for the direct stimulation of the sacral nerves and could indeed show in patients with spinal cord injury that with electrical stimulation of the sacral nerves, you can provoke bladder contraction in these people. And together with cutting some nerves, where you make a denervation of the bladder and then stimulating other nerves, you can restore the micturition cycle in spinal cord injury patients. Tanago also worked on the sacral nerves, but outside the spinal space. So the sacral nerves at the level of the sacrum. And that's another technique that we call neuromodulation. Now, neuromodulation makes use of electrical stimulation, so is a form of neurostimulation. But in this case, we do not stimulate to achieve an immediate effect on the end organ, the bladder, but we provoke a stimulation where the current goes up from to the brain, change there the activity in the paraventricular gray centers that control the bladder, and that control then will affect the behavior of the bladder. As I said before, for many urologists, that's still a difficult concept. But that is because when you look to bladder problems as a clinical problem, you can say, well, somebody that cannot pee, the bladder that does not contract, or a bladder that contracts too much, are two completely different clinical entities. But from a functional point of view, they're just the two extremes of the same process. You have a stimulation center, you have an inhibition center, and they have to be in balance. Now, if you have a disbalance in one direction, you get a contractility or hypocontractility of the bladder. If the disbalance is in the other direction, you get an overactive bladder. And it's again a basic principle. If you bring electric current into the human body, it restores the equilibrium of these reflexes. And that's the way how with the same technology and even with the same stimulation parameters, we can treat patients with overactive bladder and patients with hypoactive bladder. That's still difficult to understand for many of our colleagues, but meanwhile, more than 500,000 patients with bladder problems have been treated with sacral nerve neuromodulation. So not only this is proof of concept, but also proof that this is an adequate and very successful therapy.
And you worked with some of the very first products in this space.
Yeah, indeed. I was contacted late in the 80s. It must have been around 1988, I think, by Tanago if I was willing to participate in the first trial. I was working in Nijmegen in the department of Frans de Bruyne at that time. And so I had this specific focus on functional problems. And I had been visiting Tanago's apartment before. So when he started with the trial, he asked me to participate in the trial. I did my first implant in 1989. And that was a pivotal trial that led then to the FDA approval in 1994 for the urgency incontinence indication, and then 2 years later for patients with retention. Now, more than 500,000 patients have been implanted, so it's not only proof of concept, but also I think that now we can say this is indeed an accepted therapy, although new developments take place, new battery technology. For example, before it was not MRI-proof. The actual batteries and electrodes are MRI-proof, which is a major step forwards, of course. We have also smaller batteries. We have rechargeable batteries. And also, as I said before, developments in terms of where do you put the electrode. We have now also tibial nerve stimulation. So the classic neuromodulation, the electrode is implanted on the backside of the sacrum because there is a hole, and that hole, you can put an electrode, you can fix it easily, and it's in the neighborhood of the sacral nerve. But also there is a possibility, and this has been explored in 1983 by Edward Maguire and then in the 1999 by Michael Stoller, where also can be put an electrode in the neighborhood of the tibial nerve. And the tibial nerve, again, current will flow upwards to the brain and can have similar effects as a sacral nerve neuromodulation, although I would call tibial nerve neuromodulation the neuromodulation light. So for less severe problems, tibial nerve neuromodulation will work. For more severe problems, we still need the sacral nerve stimulation and neuromodulation. But the funny thing is that in the circle of time of history, that exactly the spot where we stimulate the tibial nerve is also one of the classic acupuncture points, where for people with bladder problems, Chinese acupuncture will stimulate exactly that point and will have an effect on the bladder. So for me, it's beautiful because that the circle is kind of closed, or the historical circle is closed by a technique that has been described in acupuncture for thousands of years ago and is still applied nowadays, although with modern technology.
Mm-hmm. Well, we see a constant miniaturization of technology, as you say. Batteries become more efficient, implants, things like that. What do you see in the near future for this field?
Well, I give already some the new developments, like for example, network of electrodes around the bladder to provoke bladder contraction, new methods of stimulation of the external sphincter for stress incontinence. As you quite correctly say, further miniaturization that we have already to a certain point for the sacral nerve stimulation, rechargeable batteries, so that are already developments that are there. But of course, there are also many possibilities with telemetry, where you implant an electrode in the neighborhood of the nerve, but you do not implant the pacemaker, but you can have a battery outside of the patient or even at distance of the patient, so that if you do not have to implant the battery in the body, it can be an energy source outside the body that the patient can put during the day when they have most problems and can take it away during the night, not to have. And then you don't have to do, because battery run out of power after some 8 to 10 years, where you have to change the battery. If you can do it with an external battery, then no need to do surgery to replace the battery. Of course, also electrode technology is evolving, miniaturization, other forms of electrodes. So there is a lot of things going on, and further, a lot of research also in stimulation parameters, because we have now, with the actual modulation techniques that we have, up to 80% success, which is great, because these are people that were resistant to the classical therapies, the pharmacological therapies, and still we can achieve 80% success in these patients, which is great. But on the other hand, that means that 20% of the patient cannot be helped with the actual technology and stimulation parameters. So it's a big challenge to see if we can, with change in technology, change in anatomical side, change in stimulation parameters, have a even better outcome, and also cure or treat the patients that are not cured or to satisfaction treated at this moment.
So it sounds like a very dynamic field at the moment that stretches back at least 200 years, maybe, and in the most wide sense, thousands of years. Then electricity,
and
therapeutic.
And also urologists take profit from the broad field of neuromodulation, because I said it's not only in urology. There is neuromodulation in Parkinson, there is neuromodulation in walking difficulties, there is neuromodulation in migraine, in other cardiac problems, stomach problems, intestinal problems. So it's a very broad field of science and clinical developments. And of course, as urologists, we can profit also from developments in neighboring fields.
Philip, thank you for your time.
My pleasure.
I should say, we are now discussing a presentation that you originally gave in Leiden, the Netherlands, in October of 2024.
Correct.
When we had our annual autumnal history office meeting, the fall meeting.
Yep.
We will be looking at some other presentations from that symposium.
Indeed, there were different lectures, all talking on the history of urology, but all with the aim of looking what's in it for the urologists of today into the history. Because many urologists still see history of urology as a hobby for some retired urologists. That can be also the case. But on the other hand, I think also that in the history, there are a lot of lessons and there is a lot of important information that can help clinicians in better understanding actual therapy, addressing, presenting the therapies to their patients, and also have ideas for future developments and techniques.
Inspiration from the past.
Absolutely.
Yeah. Well, and if as a listener you made it this far, then clearly you are too interested in the history of urology. And if you're interested in the history of urology, you can visit our online museum at history.uroweb.org. You can take a look at some of the books that we've published over the years. We have them on sale at shop.uroweb.org. I will put all these links in the description of this show. Look out for more historical talks in the coming weeks, months, and thank you for listening.